Hello everyone. So today we will go through echo findings of three diseases, that is atrial septal defect, mitral stenosis, and the Lutembacher syndrome, which is coexistence of atrial septal defect with acquired mitral stenosis. We will also discuss in brief about their clinical presentation. So this is a case of atrial septal defect. As you can see, here is the defect in the interatrial septum, and you can see the shunt from left atrium to right atrium. There is dilatation of RA and RV, and there is also some tricuspid regurgitation due to annular dilatation. So this is a case of atrial septal defect. These cases presents usually in the third and fourth decade, and the common cause of presentation is RV failure or pulmonary hypertension, and presentation is usually exertional fatigue, exertional dyspnea, or palpitations due to dilatation of the right atrium. That can be atrial tachycardia, atrial fibrillation, either of them. Now the second disease is mitral stenosis. Now if you differentiate it from the previous case, you see here that the LA is dilated, the mitral valve is stenotic and not opening well. There is a strong gradient between LA and LV, leading to the turbulence of flow, that is also called as aliasing in the color Doppler, and due to which the LA pressure is raised, which leads to rise in pulmonary venous pressure, which leads to pulmonary edema and presentation of features of left heart failure, as in contrast to the ASD where the features are right heart failure and pulmonary hypertension. Here the symptoms usually comes due to pulmonary edema and left heart failure, which is usually orthopnea, pulmonary crepitations, edema, these things. Now there is also secondary pulmonary arterial hypertension due to pulmonary venous hypertension, due to which there is tricuspid regurgitation, but the RA and RV is not that much enlarged. However, in the very late stages, RV may be enlarged due to secondary pulmonary hypertension. Now, the third disease is Lutembacher syndrome, that is coexistent of the mitral stenosis with atrial septal defect. So, how the physiology gets differed here is that the LA pressure, which should rise in mitral stenosis, doesn't happen because LA decompresses into the RA. So, this is predominantly ASD is acting like a pop-off valve for the left atrium, which leads to increased shunting as compared to normal ASD from left atrium to right atrium in Lutembacher syndrome. So there is RA and RV dilatation, but unlike the normal or usual atrial septal defect which presents in the third or fourth decade, this presents early in the second and third decade with the symptoms of atrial septal defect. So the mitral stenosis symptoms are masked and the atrial septal defects are accentuated and comes at an early age. So you can always remember Lutembacher syndrome as ASD with MS, where the MS is masked, M for MS, M for masked, and ASD is accentuated. So the patient presents with early onset right heart failure, early onset arrhythmias, and early onset pulmonary hypertension. Most important part is, if you see, there is no significant turbulence across the mitral valve here. So because the LA gets decompressed into the RA, the gradient or the net difference in pressure between LA and LV is not very high, due to which if you measure peak by mean pressure gradient across mitral valve, or if you measure pressure half time, they will all give you the false evaluation of the severity of mitral stenosis. So in such cases, we should always take mitral valve area by planimetry. Also clinically, also what happens that the mitral valve diastolic murmur is very soft or muffled and sometimes even absent, because the turbulence or aliasing or the gradient is not there. So this was in brief about the atrial septal defect, mitral stenosis, and Lutembacher syndrome. And here is the table for reference. If you want, you can just go through it, pause and see. So this is the difference between isolated ASD and Lutembacher syndrome, and this is the difference between isolated MS and Lutembacher syndrome. Thank you.